And if you would like to, you could also mute the original sound.
Danke, Oliver.
Thank you, Oliver.
Kommen wir zu unseren Sponsoren.
Now,
Unterstützung von Novartis
to our sponsors.
Wäre
without the support of Novartis,
Novartis zu uns einladen.
It wouldn't be possible to speak to you here today. And I would also like to ask the colleague of Novartis to welcome you. We are very happy to welcome you here today. And it's really an honor for us to support such events. We have very nice weather today, so I'm looking forward to fruitful conversations. And I think the speakers at these events are selected always very, very carefully, and we always have very interesting discussions. And all the best to you, and enjoy today's session.
Vielen, vielen Dank.
Thank you very much.
Now I will start to speak English because our guest is here. I would like to introduce you Dr. Michelle Couri, Medical Director, Couri Center for Gynecology and Integrative Women's Health, President MPN Peoria. Hi, Michelle. Greetings from Austria and Germany.
Thank you, Elena. Greetings from the United States.
Thank you very much that you are today with us. We will speak about very important topic for all MPNs, I mean, all over the world. We will speak about sexual health and intimacy. But before, I would like to say for all our participants, Michelle, for me, is unique woman, is a hero, because she had polycythemia vera, she had stem cells transplant. She's a doctor, and I think she's only one who is speaking about this very, very important topic for us. Michelle, floor is yours.
Well, thank you, Elena, and thank you to everyone at MPN Austria for the warm invite to speak to you all today. Like Elena said, I am speaking to you as a gynecologist about sexual health and intimacy as it pertains to the female MPN patient. But I'm also speaking to you as a MPN patient. As Elena said, I had PV diagnosed in 2011, and it progressed to pretty aggressive myelofibrosis in 2020. And so 7 months ago, I underwent a stem cell transplant that was successful, thank God. So in more than one way, I am incredibly grateful to be with all of you here today. So Oliver, if you could just help me get my slides up, that would be helpful, or at least so that I could see them.
Before Oliver showed your slides, I forgot to say we are make a video recording. That's why if you want to switch off your camera, please do it, because after our meeting, you will have an opportunity to see this video in our YouTube channel of MPN Austria Support Group. Yeah, sorry for interruption, Michelle. I forgot this. It's very.
That's okay.
That's
okay.
Yeah.
So I'm just going to see if I know our slides were up there before.
Michelle, this is because I had to share my screen before for these housekeeping slides.
They were. Yes, do we need to share again?
So please share your screen again.
Okay, we just need to share again. Okay. We will do that now. How's that?
Yeah, that's great. Yeah, everything is perfect. Yeah,
thank you so much. Okay. So like I said, we are going to focus on the female experience with an MPN, specifically as it pertains to sexual health and intimacy. So as I go through the talk, I'll be happy to answer questions at the end. You can ask me questions about anything in the presentation, or if you do have questions about what it was like going through a stem cell transplant, I'd be happy to answer that as well. So as Elena said, I've been in private practice for approximately 20 years in gynecology and women's health here in the United States. And I have a particular interest not only in women's health, but also in wellness as it pertains to exercise and nutrition. So we're going to touch base on that as well. I have no financial disclosures. So today we're going to concentrate on the objectives, which are to identify the prevalence, the causes, and the treatment options for sexual dysfunction among female MPN patients. So I think it's incredibly interesting that the population of cancer survivors in the United States is growing rapidly, as it is around the world, not just in the US. So this data is from US statistics, but in 2016, the number of cancer survivors in the US was 15.5 million. And with the population aging as it is, and with advancements in early cancer detection and better treatment methods, this number of cancer survivors is expected to reach 26 million by the year 2040. So we as physicians will be taking care of a lot of cancer survivors. And I think that when we talk about survivorship, survivorship is the time in a cancer patient's life after they have been, quote, cured of their cancer. And I think of an MPN patient as having a long period of survivorship, because MPNs usually are very slowly progressing cancers. And so we as MPN patients spend a lot of our time in this so-called survivorship. And there's lots of issues to address in survivorship, and sexual health is one of them. Sexual health is incredibly important. It is part of our identity as an adult, and it can directly impact our self-esteem and our happiness. So when our sexual health becomes dysfunctional, that can negatively impact our quality of life, especially for cancer patients and MPN patients. It is important to realize that the vast majority of women will suffer some degree of sexual dysfunction as we age, mainly because of menopause and hormonal changes. So roughly 80% of women reported some decline in sexual desire or sexual function during menopause. But it's also important to remember that the vast majority of women state that it is important to maintain an active sex life. And in this study out of Great Britain in 2013, 84% of menopausal women said it was very important to them to maintain an active sex life. So that's why we as physicians need to make sure that we do everything that we can to help our patients achieve that. This study was done in 2007, and it was published in the New England Journal of Medicine. And this study looked at over 3,000 US adults ages 57 to 85. And they found in this study that the majority of older adults do engage in intimate sexual relationships, and they regard sexuality as an important part of life. So it is a very important topic for sure. This is one of my very favorite studies because it was done specifically on MPN patients looking at quality of life. And some of you on this Zoom meeting may have participated in this quality of life international study that was done by Dr. Ruben Mesa and colleagues. And this study was done in 2016. And what this study group looked at was the symptoms of sexual dysfunction, specifically in MPN patients. And it reported that more than 2/3 or 64% of patients with MPNs have some degree of sexual dysfunction. And 43% of MPN patients reported severe sexual dysfunction symptoms. So there is a real need to address and treat sexual dysfunction among MPN patients. So in the study that was published, like I said, in 2016 in the journal Cancer, they looked at almost 2,000 patients with an MPN. And this was an international study, and it included 827 patients with ET, 682 patients with PV, and 456 with MF. 52% of the people in the study were 60 years of age and older, and more than half, or 53%, were female. The researchers in this study asked patients to rate their symptom burden with their sexuality dysfunction on a scale of 0, meaning no symptoms, to 10, meaning severe symptoms. And what they found was that the overall mean symptom burden score was 3.6, and the authors in this study categorized that as a moderately high symptom burden. And what I found fascinating was almost 11% of NPN patients rated their sexuality dysfunction burden score as severe, as a 10 out of 10. The researchers broke it down even further, and what they found was that patients with myelofibrosis had the most problematic sexuality scores, followed by those patients with PV, and followed even more by those patients with ET. So ET had the least impact on their sexuality score compared to those with PV and MF. The researchers broke it down even further into laboratory results. And what they found was that patients with MPNs that have laboratory abnormalities had worse sexuality scores than patients with normal labs. So those MPN patients that were transfusion dependent had more problems with their sexual health than women with anemia, compared to women with low platelets, compared to women with just a low white count or leukopenia. And lastly, the researchers looked at the mode of treatment of MPN as it pertained to sexual dysfunction. And they found that MPN patients who had to be on steroids had more of an impact on their sexual health compared to MPN patients that were on immunomodulator drugs such as thalidomide or lenalidomide. And those patients on interferon had the least interference with their sexual health. So what are the causes of sexual dysfunction in MPN patients? Well, MPN patients, we are a unique group of patients because we have a constellation of symptoms. We typically see high levels of inflammation in MPNs. The MPN symptom burden can be quite large. MPN patients can suffer from fatigue, anxiety, and depression. We may also have chronic itching, or what we call pruritus, and sleep disturbance can be quite common among MPN patients. Poor body image also can cause sexual dysfunction, and poor body image can occur because of what the MPN disease does to our body. We may have difficulty losing weight, and we may feel that we're just too thin and we can't gain weight. Sometimes the medications for MPNs will cause excessive weight gain. Those of us that have had a stem cell transplant because of our MPN, obviously we lose our hair, so that affects our body image. So there's lots of things that can make us feel less desirable because of a poor body image. And lastly, there are MPN treatment-related side effects. So many of the medications used to treat MPNs may have an effect on our sexual health. So what exactly is female sexual dysfunction, and what does it include? Well, female sexual dysfunction includes what we call inhibited sexual desire or low libido. It also includes the inability to become aroused. It may also include delayed or absent orgasm, or what we call anorgasmia. And it also includes painful intercourse, something that is in the medical literature is called dyspareunia. So all of these variables make up female sexual dysfunction, and patients may have one or two or all of these symptoms. Sexual dysfunction occurs in men as well, and it does increase with age, just like it does in women. Obviously, we're focusing on females during this talk, but sexual dysfunction in men does include decreased libido, erectile dysfunction, and ejaculatory disorders. So what are some of the factors that will influence a woman's level of interest in sex? And there's many. One of the most important factors that will influence our interest in sex, our libido, and how we respond to sex are our hormones. And there are a lot of hormonal changes that can happen throughout our lifetime, especially in menopause. In menopause, we typically will lose our estrogen and our testosterone because those levels significantly decline. And with the decline in those hormones, our body goes through a lot of changes, and those changes can have a negative impact on our sexual health. Sleep disturbance is another factor that will affect our level of interest in sex. Our mood, depression or anxiety, very tightly linked to our interest in sex. Stress, medications and their side effects will have an effect on our interest in sex. Living with health concerns, so living with a chronic health disease such as MPNs, and living with chronic pain. All of these can take a toll on our sexual health. And if you look at this list, many of these variables coexist with having an MPN. And that's why MPN patients are particularly more susceptible to sexual dysfunction. Mood disorders are prevalent in MPN patients. So on that previous slide, I mentioned anxiety and depression. And this study was done in 2019. So it's a recent study that looked at MPN patients and our moods. And the study found that 21% of MPN patients suffer from anxiety, 12% suffer from depression, and 8% have both. So as you can see, this alone can set us up for having a negative impact on our sexual health. And I find that this problem is kind of like a vicious cycle, because the more symptoms and fatigue that we have from our MPN can lead to a higher level of sexual problems, and that can increase our anxiety and depression. And then the more anxious and depressed we are because of our disease can then increase or exacerbate our symptom burden of our MPN. So it's kind of, like I said, this vicious cycle. On that list of things that can affect our sexual health, chronic pain was one of them. And this study was done in 2018, looking at pain in NPN patients. And the study found that pain management in NPN patients may be undermanaged. More than half of patients with MPNs report feeling pain that is related to the disease itself. And most commonly, the type of pain was abdominal discomfort in 53% of NPN patients and bone pain in 48% of NPN patients. So this abdominal pain may be due to our spleen being enlarged. This bone pain, again, is something that can be seen quite often because of the disease itself. And so when women and men live with chronic pain on a daily basis, that has a negative impact on our sexual health. So how do we treat female sexual dysfunction? Well, if there's one message that you take home from this talk today, it is this: female sexual dysfunction is treated in a number of ways. There's no one size fits all. We have to accommodate the treatment according to what the patient needs the most. And so as a gynecologist, I spend a lot of time providing education to my patients about ways to improve sexual health. We talk about what is normal human anatomy. What happens to our body as we change, as we age? What bodily changes take place? And what happens to our body as we go through menopause and we have hormonal changes? How does that affect our sexual health? We spend a lot of time talking about lifestyle, like exercise, the importance of exercise and the importance of eating healthy and limiting alcohol, because alcohol can have a negative impact on our sexual health. We talk about setting aside time with our partner, like setting aside date nights where we are committed to each other and we clear our calendar so we have time to be present with one another. We talk a lot about relaxation techniques, how to escape the daily stresses of our MPN disease, ways to kind of relax and disassociate from living with the burden of a chronic disease. I talk to couples about distraction techniques. Sometimes for sexual health, it's important to engage in fantasizing or role playing, just trying again to distract from some of the things in life that may be causing our sexual health to be less than optimal. We talk about the importance of music as a way to relax and get us in the mood, and even using meditation. And we'll talk about meditation a little bit in this talk. I also talk to patients about encouraging non-coital behaviors, meaning don't jump right into intercourse, because it does, foreplay and getting in the mood is really important. Most people dive right into sex, but it has been shown that at least 15 to 20 minutes of foreplay is crucial for building our sex drive and building our sexual response. It is absolutely critical to minimize pain with intercourse. A lot of my patients have pain with intercourse, and these are women of all ages, but the pain with intercourse is more commonly seen in my menopausal patients because of the changes that happen when we lose our hormones. So we'll talk about ways to improve vaginal dryness and the pain that can happen with menopause. And lastly, we will talk about medications that we can use to improve our sexual health. So the bottom line is, as a patient, it is really important for you to be comfortable in talking about your sexual health. This study was done in 2007, and it looked at female cancer survivors. And 74% of female cancer survivors believe that physicians should regularly ask about sexual health. But 64% of these cancer survivors state that the physicians never initiate the conversation during their care. So my message to you is, it is okay for you as a patient to initiate the conversation with your physician about sexual health, because it is an important topic, and we as physicians are here to help you. This study also was done in 2007, and it was a survey of oncologists, of cancer specialists. And 80% of cancer specialists felt that they wanted to take a sexual history with their patients, but there wasn't enough time in the visit. So we know when we sit with our MPN specialists that there is a lot to talk about. We have to talk about our blood counts. We have to talk about our medications that we're on. We have to talk about how we're feeling. So there's a lot of ground to cover, and a lot of time there's just not enough time in that visit to bring up sexual health. And that's why we're going to talk about ways that you can do that using a team approach. And the team approach starts with you as the patient. You are the center of the team, and you are the most important person on the team, you and your partner. But it does take a team. So the team can include your MPN specialist or your hematologist. It very well should include your gynecologist or your female health expert or your primary care physician. So that way we are all on the same page in collaborating with each other and directing the most appropriate treatment for you. So let's start off with using your gynecologist or your female health expert as a starting point. Because most of us gynecologists, we spend a lot of time talking about sexual health. And we do know that one of the most common problems that can cause sexual dysfunction is painful sex. And so when sex becomes painful, whether it's due to menopause, or maybe it's because in our younger patients, there's a problem, a pelvic problem that is making intercourse uncomfortable, we need to get to the root cause of what's going on. So making sure that you are up to date with your gynecologist, make sure that you are up to date on your pap smear and your pelvic exam, so that we can figure out why intercourse is painful and make sure that we can help you fix it. For our menopausal patients, the most common cause is vaginal dryness, the thinning of the vaginal tissues, and the tightening of the vaginal tissues, because as we age and we lose our hormones, we lose the elasticity of our vagina. And this occurs in 64%. Intercourse is painful in 64% of menopausal women, so we see it quite often. And 55% of women with painful intercourse say that the pain is moderate to severe. So when someone has moderate to severe pain, it is not, it is understandable why someone would want to avoid having intercourse if it hurts that bad. So that's why it's very important to talk about it with your doctor. How do we minimize pain with intercourse? There's several ways. One of the most important ways is to make sure that we add back moisture to the vagina, especially for our menopausal patients. So in our menopausal patients, we tell them to use a lubricant every single time with intercourse. And lubricants are over the counter. They're usually very easily found in the stores or online. They can be water-based or silicone-based. I've listed a couple of my favorite products. You just have to be careful with silicone-based lubricants and using condoms, because the silicone can affect the integrity of the condom. Other lubricants that are natural that some patients prefer using include organic coconut oil or vitamin E oil with or without aloe vera. So these lubricants are also completely safe and can be used and should be used each and every time with intercourse. Now, vaginal lubricants are different than vaginal moisturizers. Vaginal moisturizers add moisture to the cells in the vagina, and they are intended to be used several times a week on a regular basis. So vaginal moisturizers, at least in the United States, come in many different brands. And I've listed a couple of brands here that are the most common in this country. One of them is called Replens Long-Lasting Vaginal Moisturizer. And the other group of vaginal moisturizers include hyaluronic acid, similar to what we use on our face to improve the moisture content in our cells. So all of these products are completely safe, and we definitely encourage our patients to start with them if they're experiencing vaginal dryness. The lubricants that I would say that I would recommend that you avoid are a couple of the most common ones, at least in this country: KY jelly and Astroglide. those are not the best because they actually draw water out of the cells of the vagina because of their high osmolality. So stick with the ones, like I said, at the top of the screen, the water-based or the silicone-based. Another area that is incredibly important, especially in our menopausal patients, is using vaginal estrogen. Like I said, when we go through menopause, we lose our estrogen and our testosterone. And for most MPN patients in menopause, it is not recommended to be on estrogen because estrogen can increase the risk of blood clots. And MPN patients are already at a higher risk of that to begin with. But vaginal estrogen is completely safe to use in menopause, even in our MPN patients. Vaginal estrogen comes in the form of a tablet, a ring, or a cream. At least these are the most common products: the estradiol tablet, the estradiol ring, and the estradiol cream. These are the most common here in the United States. Another vaginal hormone that is very helpful at eliminating vaginal dryness is vaginal DHEA, and the brand name is Intrarosa. That is a vaginal suppository that's used daily, and that converts to estrogen and testosterone. So these vaginal hormones are really important at improving the health of the vaginal tissues to eliminate dryness and pain. And lastly, vaginal pain does not always stem from menopause or from vaginal dryness. We see a lot of young patients with and without an MPN that have pelvic pain or vaginal pain and painful intercourse. And we recommend pelvic floor physical therapy to those patients because a lot of times the pain with intercourse can be due to a musculoskeletal problem. There might have been an injury sustained during childbirth. There might have been an injury to the pelvic floor. And this problem can be cured using physical therapy of the pelvis. And so we here in the States, we use this modality quite often. Sometimes the problem with sexual dysfunction is not always physical. Sometimes the problem can stem from a problem with the relationship. So if we're having a problem with our partner and that problem needs to be treated with a sex therapist or a psychologist, then using these services is really important. This kind of adds to the team approach, like I mentioned, when we're addressing the problem with sexual dysfunction. This slide is a reminder that there is a great deal of benefit in what we call mindfulness-based therapy as it pertains to our sexual health. We do know that mindfulness-based therapies such as meditation or breathing exercises or guided imagery, these techniques work to improve sex drive in women, and this was based on a study done in 2017. We also know that these techniques reduce our stress hormone levels, and stress hormone levels are known to cause low libido or decreased sexual desire. All aspects of sexual function and sexual well-being exhibited significant improvement when women used mindfulness-based therapy. Again, these are quick and easy to learn. There are several apps that will teach mindfulness-based therapy. And so I always include that in my discussion with my patients. As we kind of start to wrap up this discussion, I don't want to leave out the importance of lifestyle. Lifestyle is incredibly important for every disease, including MPNs. This study was done last year in 2020, and it looked at body mass index among MPN patients. And I found this study to be very interesting. What they found was that among many MPN-related symptoms, including sexual dysfunction, there is a higher symptom burden among obese MPN patients compared to MPN patients of normal weight. So if you look at the statistics, 71% of obese MPN patients reported sexual problems compared to 62% of normal weight MPN patients. So it is incredibly important that we try to maintain a normal weight. The reason why I think that obesity leads to more symptoms with an MPN is because the more weight that we carry, the higher the levels of inflammation in our body. So that is another reason to be very, very cognizant of the importance of maintaining an optimal weight. A lot of times how we eat can be directly related to our weight, not always, but there can be often a direct correlation. And because MPNs tend to be a disease of high levels of inflammation, if we ate in a way that is anti-inflammatory, that could definitely improve our symptom burden. And this diet pyramid is an anti-inflammatory diet pyramid that is very similar to the Mediterranean diet. And the Mediterranean diet, or this anti-inflammatory diet, is rich in colorful vegetables and fruits. So eating multiple servings of vegetables and fruits a day can help decrease our levels of inflammation. We do know that omega-3 fatty acids will help to reduce inflammation, such as what we would see omega-3s in what we would see in like wild Alaskan salmon or black cod. Also in our diet, we should combine lots of healthy herbs and spices because all of those play a very important role in reducing inflammation and providing antioxidants. We really want to minimize sugar intake and minimize processed foods because all of those can lead to more symptoms and more inflammation. And lastly, exercise is so important for so many medical problems, including myeloproliferative neoplasms. We do know that exercise does improve sexual function. It improves sexual arousal or our desire for sex. It can enhance our sexual satisfaction. It improves our body image, and exercise improves blood flow and circulation, which is so important for MPNs. I know that not all MPN patients can exercise to the same degree as everyone else. Sometimes we have symptoms from our MPN that prohibits us from doing high impact or cardiovascular exercise. But I tell patients, it doesn't mean that you can't do gentle exercise, even with an MPN. And this study was done in 2019. It was a small study of 48 MPN patients, but it showed that 75% of MPN patients felt that yoga was very helpful in coping with MPN symptoms. Yoga can improve the symptoms of depression and anxiety. It can help with our fatigue. Yoga can improve our sleep quality and quantity. And 26% of middle-aged women do suffer from insomnia, so it's a very common problem. And yoga also can reduce levels of inflammation. And in this study, it was shown that it reduced an inflammatory marker called TNF-alpha. So even if you can't get on the floor and do yoga, you can do chair yoga, you can do Tai Chi. All of that is very important in reducing our symptom burden. And lastly, most of the ways that we can make sex better is by communicating. So communicate with yourself, communicate with your partner, communicate with your MPN specialist, your gynecologist, your family physician. I encourage you to eat well and exercise regularly. Try to get a good night's sleep. That is incredibly important. And there was a study done this year that showed that sleep quality is more important than sleep quantity as it pertains to our sexual health. I think it's important to tell patients to let go of the way that sex used to be. Our bodies are constantly changing. The MPN may change us in ways that we had no idea. And it's okay to let go of the way that it used to be. Sex may not be the way it was when we were 20 or 30, but it can still be enjoyable. We just have to adapt. We have to be patient with ourselves, and our partner needs to be patient with us as well. Become playful and be willing to experiment. And I can tell you that there's always a way to make better sex. So thank you very much. And I would be happy to answer any questions that anyone might have.
Thank you very much, Michelle. Maybe I will open our session of questions and answers.
Yes.
I will start with some questions, and then I will be very glad to hear from you, our dear participants, because I think this topic is very, very important. Michelle, you told us that in menopause we lost our hormones, and you told us that for us, for MPNs, it is not very good to take them because they can produce clots.
Yes.
It means that for ladies in menopause, we should tell our doctors, please don't give us hormone therapy, because some gynecologists, they usually tell us, okay, if you're in menopause, then you should take important hormones.
Okay, yes. So Elena, that's a great question. And the problem is that if you take estrogen by mouth or you take it orally, it can increase the risk of blood clots in women with or without an MPN. There are safer forms of estrogen, like transdermal or a patch or a cream, that do not increase the risk of blood clots as much as oral estrogen, but it still has a slightly higher risk than not taking the estrogen. So a lot of gynecologists and MPN specialists shy away from MPN women using estrogen in menopause just because of the fear of blood clots or stroke.
Okay. Thank you. You told also a very interesting thing about team of doctors and patients. I mean, general practitioner, oncologist, gynecologist. How does it work in United States of America? Because I can tell you in Austria, they are very separately, and the general practitioner will never talk with the oncologist, yeah, and the patient, I would say, we're here like a small bridges between all the doctors, yeah, and we should bring the information from one doctor to another.
Yes, yeah, and it's sometimes like that in the States as well, depending on the particular physician, but most of the time, we try to have a collaborative relationship where the MPN specialists and the family physician or the gynecologist are in close communication, because we know that everything is fluid, right? The patient has so many symptoms that may cross different different boundaries, right? It's so the gynecologist may be treating sexual dysfunction. The MPN specialist obviously is managing all the specifics of the MPN, but the issue lies that collectively we are a whole, and we need our physicians all on the same page. And so we don't want one hand to not know what the other hand is doing, because then unfortunately it can lead to some problems for the patient. And so I always encourage patients to try their best to keep all their physicians educated about what is going on and keep them informed. And I think it's important that we be our own advocate. We need to make sure that we are asking the important questions, even if our doctor isn't bringing them up.
That's why it means it's very important that the patients should speak or should ask questions to the doctor about this sexual health, and not wait when the doctor will ask how is his sexual health and intimacy. I mean, yeah.
Yes, because 80% of the time they are not going to ask, just because of time constraints. It's not because they don't care. It's just there just usually isn't enough time. So that's why we have to feel empowered to ask that question.
Now I would like to ask our auditorium, maybe somebody have questions to Michelle. I see here not only the members of MPN Austria support group, also guests from Germany. If you would like, you can write your question in chat.
Yes, and feel free to ask me anything. If I don't know the answer, I'll be completely honest that I don't know, but I'll be happy to answer any questions.
I know some members of MPN patient group. Hertha, would you like to ask some question, or Krista, Elfrieda? I think we should use this time to ask Michelle all our, I would say, ladies' questions, because I recognize in a lot of pages of your presentations, Michelle, my anxiety, my fatigue, my depression, and yoga and Qigong help me to forget about these symptoms. I mean, yeah.
Absolutely.
Ladies, they don't have questions. Yeah, then I would say thank you very much, Michelle, for your time, for your explanation. It was very important. Each of your slides was very important, had very important information for us. And I hope we'll see each other maybe in 1 year. We would like to invite you to visit Vienna and have a good day. Have a good evening for Austria and Germany, and see you later.
Thank you, Elena, and thank you everyone that tuned in. It was, like I said, a true blessing. And my one wish and prayer for all of you is that you continue to enjoy good health. And I wish you all the very best.
Thank you. Thank you. Thank you. Thank you. And bye. Bye.
Bye-bye.
Bye.